Hello, everyone. Stewart Gandolf with another podcast. And today we are interviewing Dr. Lyle Berkowitz. He is founder and executive chairman of KeyCare. And I got a pretty good sense Lyle will be able to share some thoughts and ideas pretty easily. Welcome, Lyle.
Glad to be here.
I think Lyle and I are not known for being shy on these kinds of topics. So I'm sure we're going to have a fun and stimulating conversation. So I'm really looking forward to this. So Lyle, I would like to start off our audience. I've gotten to know you and know a bit about KeyCare, but I would love for you to share and brag a little. It's okay about your background and then specifically about KeyCare and what you're doing. And then we'll take it from there.
Sure. Well, so I wear a couple hats. I was a biomedical engineer, who became a physician, who became a system executive, who became a doctorpreneur. So I've been able to meld all these things in my career. And all of these things often happen at the same time. So I spent much of my career as a primary care physician and a system executive at Northwestern Medicine in Chicago. My executive skills focused on IT and innovation, rolling out EMRs, looking at new companies, new ideas, et cetera, and figuring out how to get them up and running in a large academic medical center. Along the way, I was also got pulled into a variety of business activities. I was chief medical officer for two publicly traded companies and an advisor and eventually founder of multiple other digital health companies over the years. And after 20-something years at Northwestern, I left and went full-time into the business world, serving as an executive at MD Live, one of the big telehealth companies. Did that for a few years, helped them scale up. They eventually sold to Cigna. And then I focused on one of my other companies called HealthFinch, which was in the workflow automation space. We sold that to Health Catalyst. And then I thought I would just focus on investing and consulting, et cetera, but got pulled into one more company called KeyCare, which we'll talk a little more about today. But the idea here is it sort of took all of my history. As a doctor, as a health system executive, as someone who's rolled out and worked with Epic, both as a user, an implementer, but also some of my HealthFinch company was one of the first apps on their app orchard. And we started the nation's first and only telehealth company organization group that is using Epic as our base EMR and telehealth software so that we could provide access to the nation, but do it in coordination with the many other health systems that are using Epic already, rather than provide access that would actually be more of a vacuum and separate out their care from the typical care that they get in the health systems. So I'll stop there. So that gives my 2-minute overview for you.
That was really helpful. So the one thing I want to clarify too is in terms of KeyCare, you're not just providing a software platform that others can use. You're actually providing providers through the platform. Is that?
In fact, we do not sell technology. We are a tech-enabled service. We provide access to a virtualist workforce that is working on our instance of Epic that we've optimized for highly efficient virtual care, and we've optimized for working in coordination with all these other Epic health systems by using all the Epic built-in interoperability functionality that allows for data sharing, as well as cross-instance scheduling, messaging, etc.
So I find it really intriguing, and it's funny. I think about this a lot lately. So in terms of my own career, I spent about 10 years interacting with thousands of doctors, leading a couple hundred seminars, and that was so priceless. And I wish I could take all the knowledge of that and put that in the brains of people on my team or others, because it's just a different perspective having done that. In your case, having worked as a doctor level, at the technology level, with the health system level, gives you, I'm assuming, some insane insights about the world and where the opportunities are. Does it? Because it's in my experience, it's like that's hard to replicate. You can't read that in a book.
Yeah, working in a health system, of course, gives you that experience. It's a large matrix organization, and different people have different ideas and thoughts. There's some common goals, but when I walk into a health system and say, "Hey, this is what we're doing. We want to partner with you. We want to help see your patients," they need to trust that I know what I'm talking about. I need to know who who I need involved. How much is IT versus clinical, versus strategic versus financial, and really think strategically that if I'm going in and asking them to change anything, I got to make their life a lot easier. And different executives have different levers as to what that means. And so, yes, it gives me advantage having been in there, as well as having rolled out Epic and having, been on the other side. I've been in the side that gets pitched to. Yeah, I was the head of innovation at Northwestern, was the person people would come to and say, hey, you should use our technology, our service. So I know ahead of time what questions they can or should be asking. And so hopefully I'm a little more prepared, and I'm a little more empathetic to the issues they have to face when they think about working with a new partner.
So we see and because of our, fortunately, we've been working a long time, our SEO and our, AI SEO, and people find us all the time. And a lot of times we get called by, among the many people call us would be startups. And sometimes they're VC. I just got off the phone with a VC-backed startup actually minutes ago prior to this call. And sometimes they're just sort of mom and pop, but I'm always intrigued with the product. I always talk about when I'm speaking about marketing that amateur marketers go straight to promotion, but the really smart ones start with the product and they start thinking about what needs do we fill. How did that journey happen? Like, what were the insights that led to KeyCare as being something that was worth, spending your considerable time, brain power, resources towards? Because that's really, to me, the most exciting part is the seed of that idea. Where did that come from, and how did that develop based on your experience?
So on one hand, I find that, again, as my background in engineering and innovation, I really like to rethink what I'm doing every about 5 years. And so I spent, 4 or 5 years in the telehealth arena, and was like, okay, I've done that. What am I going to do next? AI, this, et cetera. This is, around the dawn of COVID. So it's 2021 or so. And on one hand, I said, well, I don't need to do telehealth. I've done that. But on the other hand, I said, but the problem with the traditional third-party telehealth companies is they're not really integrated into the fabric of healthcare. And pre-COVID, it was a niche. But post-COVID, all of a sudden, everybody was doing telehealth. At one point, for a couple of weeks, that's all you could get. And I recognized that there was an opportunity to do telehealth in a way that made more sense because it was coordinated with the longitudinal care. So I took my background as a primary care doc who likes to have lots of background data on a patient, and as a health system who recognizes that when we take care of a patient, the more data we have about them makes it better and easier to take care of them. With my knowledge about Epic, which had only recently really developed a mature telehealth product. So it all just sort of came together in a world where post-COVID, you had all of a sudden, patients and doctors were exposed to the fact that telehealth was very viable. You could do it. It actually makes sense. 2, there was a funding mechanism, which wasn't there before. Insurance companies now will pay for telehealth. And 3, some of the best automation technology from AI to other pure automation makes the most sense in a purely virtual world. And 4, we've had decades to understand that pop health means that you treat different patients differently, and patients who are at the upper and top of the pyramid, the most complex patients, they need the most time and attention. But people at the bottom of the pyramid, what if you could load balance them to a much lighter weight, quicker, easier type of care? And that's where this concept of the virtualist became increasingly important. The idea that I lived through the world of the hospitalists, hospital-based doctors. What if the virtualist, really could not only take care of patients online, but do it in a faster, more efficient, and better way because they had different thought processes, had different technology, had different business models, et cetera. So all these things came into play. But quite honestly, the true impetus was the fact that COVID made it a much more viable option. And much more health systems became much more interested in telehealth.
It's so funny. I remember that period, and we were doing some webinars with one of the leading telehealth platforms back then. And it was interesting to see, and this was something that I always thought, I've been speaking about, Lyle, for years, like patient experience. What do patients want and what do the hospitals and doctors want? And they're often diametrically opposed, right? The patients want to be able to communicate with their doctors and make appointments online. They're steadfastly opposed. And telehealth is another category where, within a matter of weeks, health systems that said they can't do this ever were fully engaged, right? And so you mentioned that reimbursement was a big issue and HIPAA was the other issue. And suddenly those were sort of temporarily suspended, and that just changed everything. And what's always interesting to me too, Lyle, is when you have that inciting incident, it's not just what's happening now, but what does that mean for the long term? And I love that you guys got that. So I wish we had more time. That's a fascinating topic of how that change enables everything. And then, of course, mental health has fundamentally changed forever, right? Rural healthcare has fundamentally changed forever. And even, the basic stuff that fortunately is all I need, I still get options from my doctors now to have a virtual follow-up. And like, duh, do I want to do that? Or do I want to start over and go back and sit in their office for routine checks? So I think it's amazing. Let's talk about the virtualist. I love that terminology. And how do you see that as going to be right now? It still feels pretty new, but do you feel like this is going to be integrated just completely into care? Like this will be as common as hospitalist? And how does that, and when you talk about this, there's always a status quo in healthcare. So getting used to new habits, even if it's available, they may know it's available, they still don't use it. Like, how is that going? Kind of where are you in the development there?
So what I started finding, a couple of years ago, but even more so now, is that there are an increasing number of doctors who want to be virtualists full time, not simply on the side. So all doctors, of course, can and should do a little virtual care now and then. Just like many doctors still did hospital care off and on in a variety of ways. But what happened was we recognized that it made sense to have someone who's dedicated to the hospital so the doctor could focus on the office and didn't have to go in early, et cetera. In the same way, we're starting to see that asking an office-based doctor, I'm going to call them an officeologist, to do a little office-based care, a little virtual care, there's a cognitive dissonance there that makes it actually inefficient for them. I think the best way to solve that might be if they just say, look, I'll do Thursday afternoons, I'll just do virtual care, but that they'll never be true experts in it. Meanwhile, these virtualists are doing solely virtual care, and they're becoming experts on how efficient they can be, the quality, how do they make up for the fact that they're not physically able to touch someone? They're able to look and see things online that actually they may not get to see in a office setting, right? Being able to see someone's home has some clues that can be helpful, seeing them in their natural habitat. But also we're starting to see interest in technologies that allow for vital signs or other metrics that can be presented to the virtualist. The virtualist just has a different mindset, right? Their goal is, how can I take care of you as best I can, even if I don't know you from before? And we're going to focus on doing this routine care, but relatively efficiently. The patients love it, as you said. And I'll go to that in a minute. But the virtualists have a different mindset. They are interested in seeing a high volume of more routine type patients. And they love the fact that they're able to help these patients who often don't have a primary care doc or don't have easy access to a primary care doc. So they get a lot of positive feedback. And quite honestly, they're much more interested in seeing a high volume of lower acuity, lower complexity stuff than a small volume of high complexity stuff. Specialists often want to see the higher complexity things. Office-based primary care docs are going to start having to balance that maybe they need to see more highly complex stuff in the office and leave the lower complexity stuff to online care. That will be a shift that we can talk about later because it may involve a lot of different aspects. Patients, meanwhile, as you said, have overwhelmingly said, we want options. We want an option to quickly see a doctor online. Even though doctors in the office don't necessarily want to do that, the reason that we've seen a decrease in virtual care is not because patients want to come back into the office. It's because doctors in the office don't want to do a lot of virtual care. It often is less efficient and less economically viable if they're in a pure RVU type of bonus position. So the rise of the virtualist should ideally work in conjunction with the officeologist becoming, shifting to doing more complex care, but only if we can pay them appropriately to do that.
And it always comes back to reimbursement as such a critical part of all of this.
Yep.
There's so much to unpack there. So I moved away from my primary care doctor, even though I liked him because he was with a local medical group, which was good. But the Hoag system here in Southern California is amazing. And what's happening is my kid, no, by the way, I've figured this out once, about 74% of the time a normal doctor is closed. And everybody's sick on on the weekend or after hours. And, we had small kids. So we made that change to go to Hoag because they have multiple urgent cares. It's always fast. So that convenience factor, fortunately, if you don't have huge health issues, your convenience is a big, big deal. Mm-hmm. And it's funny that this market we're in is more generally upscale. People are more used to being treated this way, which I think is part why the doctors are offering us telehealth because they just sort of demand it. But there's a lot of people kicking and fighting. Meanwhile, telehealth is like the emerging part of this. So. And you mentioned also, I was thinking about primary care. I used to go see when I was sick. I don't go see the primary care when we're sick. Now I go to the urgent care. And so instead of trying to wait to get in for 2 days, you can get in immediately. You're in and out. And so at least in my experience, the primary care is more of a quarterback of your healthcare versus your everyday doctor in this market. And so I can see that evolving. The telehealth aspect is interesting. When you're the doctors that you guys are contracting with, I guess if I'm looking at it from their point of view, are they usually part of a much larger group or a health system? Are they individual doctors? Like, who are your customers for KeyCare?
And who are our providers? Who are our doctors?
Yeah.
The virtualists that I'm talking about are often independent providers. They are not part of a health system. Now and then you get a doctor who may work part-time for a health system and then wants to work part-time for us. But more and more of these folks are full-time. They purposely have left the health system. One of the reasons they want to be a virtualist is this flexibility, convenience that they can, they might be a mother who wants to work, during school hours when the kid's not home, but wants to be there to get their kid off and be there when their kid comes home. It might be someone who likes to do other things during the day and just wants to work evening hours, etc. But many of the time we hear the same story that I worked at a large health system and they were just treating us like a commodity. And they just felt like they wanted to be on their own, but maybe they wanted to live in a rural area or they didn't, they didn't want to be associated with it and be a cog in the machine. What we're trying to do is create sort of an old fashioned medical group. We meet every month, we talk amongst ourselves, we listen to our physicians and their needs, and we try and give them the right balanced life. So all these things come into play. I worry a lot about health systems who hire a bunch of bureaucrats to oversee doctors and tell the doctor, you've got to increase your RVUs, you have to, see more volume, et cetera, and don't look at the holistic part of it. The reason we're having burnout is often because doctors are put in a position where they are, slaves to the RVU, and they've got non-doctors telling them, you have to work harder, you have to work faster, et cetera, without understanding everything that it is to be a doctor these days.
So do you find recruiting is relatively easy for you at this stage, or do you feel like and it's interesting because there's a balance, right? As people move away from primary care, certainly primary care is very competitive and there's, nurse practitioners and PAs and all of that. And I think you told me before that it's almost all MDs currently too. Is that correct? Like how's your recruiting going?
And we started with MDs, but we're starting to add in NPs now. But it's majority of MDs now, but we'll add in NPs. We think they make great virtualists. We, in a world where there's a bit of a doctor shortage, you'd think we'd have trouble, but we actually have been quite fortunate in recruiting. I think it's for two reasons. One, is there are more and more doctors who are interested in this lifestyle of being a virtualist. And two, they don't have a lot of options. Their options out there may be, working for a company that's just prescribing one drug over and over again, or just doing urgent care. If they want to be true doctors. One, it's really important for them to be on a true EMR, and the fact that we have Epic became a much bigger selling point than I realized for recruiting doctors, because most every doctor these days has been trained and has used Epic at some point. They have a lot of trust and respect for it. There's no perfect EMR, but when they're working on Epic, they know that there's going to be the ability to access past information because of Care Everywhere's interoperability network. There's going to be a level of clinical decision support that they may not find in certainly homegrown systems or even other EMR systems. They're going to get the best of breed. And that's actually really important to them, on top of the fact that we also have the ability for them to act as a true primary care doctor, not simply a one medication okay doctor or just urgent care, but that they can actually do urgent care, preventive care, chronic care, longitudinal care, things that they can't do in other virtual care settings in many cases.
That so makes sense to me intuitively. I love these insights you're sharing. Because I can see if somebody were just prescribing the same drug all day long, it can't be very professionally fulfilling. And, having worked with doctors over the years, some, for example, just want to be done, the classic, I'm a surgeon, I want to see them, I want to be done, I want to move on to the next one. Others, the idea of palliative care, like, wait, no, I don't want any part of that. Others are, want to be with the patients for the long term. And some, are drawn to the idea of this virtualist. I can see why they would be very appealing. You live where you want, you're setting your hours, you get to do what they want to do. And then within that, they still have a choice, right? So I think that's really exciting. Let's talk about. I want to talk more about the software side of it in just a moment. But before I do, in terms of the customers, like that you're pursuing, is it usually health systems, or who are your customers typically? And is that going to change over time, or how is that going?
So phase one was definitely health systems, Epic-based health systems who have access issues, who want to expand capacity to providers because they have issues with patients being able to come in and see them. So if we can help, number one, just add capacity, that's great, because then they get the downstream revenue associated with that. They get to improve keepage, decrease leakage, have room for new patients, etc. Additionally, they'll next recognize that they can do some load balancing, meaning they can shift some of the lower complexity care to our virtual team and therefore open up room for more complex patients that, quite honestly, have more value to the health system as a whole and need to be seen in the office. So there's a access and quality and marketing and business type perspective to it. We've also found that as the rest of the health ecosystem, recognizes how many folks are in Epic, that as we talk to payers and labs and pharma and others, they all say, look, we also want to have a national virtual medical group helping take care of our patients. And the fact that you work on Epic and therefore are able to have access to past information more easily, are able to share whatever you do with the doctors in the regional areas via Care Everywhere, becomes another bonus, and makes them realize that instead of just working with a third party that sees patients in a vacuum, they can work with us, and the care that we provide is not only timely but also can be coordinated with the rest of healthcare. So we believe that the nation really needs a national primary care medical group that's virtual, and being on Epic makes it that much easier for us to service everybody in a higher quality, more efficient, coordinated way that just makes sense.
So I'm curious, I want to talk more about Epic in just a moment, but the one question because I'm thinking about some of these key problems in our country, like rural healthcare or value-based care, and I'm assuming you're with health plans or various entities are also interested in that, not just the local health system, but serving people rural is tough. Being able to, have value-based care really, and when it affordably, can be tough too. Are those some things, areas of growth you guys are looking at as well over time? Or I could also see, well, we'll do that, but right now we're really focused because we have plenty of health plans knocking on our door. We'll worry about that later.
Oh, as we talk to health plans, what we hear is usually some aspect of, hey, we have a bunch of patients, who we are at risk for.
Yeah.
Some of them don't have a primary care doctor at all. Some of them have a primary care doctor, but they're not getting the care that they need. Can you come in and start, closing care gaps, being available so the patient can talk to you instead of going to the ER, et cetera. So it's, again, you said earlier, it's about reimbursement, incentives. I never got an MBA, Stewart, but I learned one thing in business, and that is incentives matter whether you think they do or not.
Yeah.
So when we talk to health systems or plans, it's, we go with, and this is something that got drilled into me at Northwestern, is what problem are you trying to solve? We don't come and say, hey, we have a solution. We say, what problems are you trying to solve? Is it increasing access and capacity? Is it improving the preventive care and care gap closures for an at-risk population? Is it making sure that patients go to the right level of care so they don't go to the ER, they can do something that's cheaper online? Who's at risk for this? Because who's paying for it, et cetera. In a lot of the cases with health systems, we actually credential and enroll into the health system so that we can take the same insurance and be aligned with the health system that way. And if they have a value-based type of operations, even better, because we are custom made for value-based care. We decrease ER visits. We, allow for much quicker, faster, efficient closing of care gaps, annual wellness visits, et cetera. I always say I want to have a company that works in fee-for-service, but can really explode in the value-based care world. And plans, by default, are going to be much more aligned toward value-based initiatives because they are often at risk for the patient, and therefore providing fast, efficient, available online care is almost always going to decrease their costs over time.
Yeah, it's such a key thing, especially we've worked with a virtual or VC-backed company doing rural healthcare delivery, and it's those patients in the rural healthcare, often older, poor, not seeing doctors, and where they end up in the ER. And so that's a real problem to be solved. Let's go back to Epic. With Epic, is we've already talked about it a little bit, but any other key insights of sort of riding the rails of a common technology? Because it's really intriguing that you didn't try to partner with every possible, practice management system / EHR. You picked one and the leader. I'm assuming that's been central to everything you do. And if someone were to say, yeah, but you could do this one and this one, what would you tell them?
Well, we picked the market leader, right? At this point, I've seen different statistics as to how many health systems they work with, but I'd say it's a reasonable estimate to say that 60 to 70% of all healthcare is run through Epic in some form or fashion. Two, there really aren't many other EMRs who could handle this from a technical perspective. Epic's Care Everywhere interoperability network is profoundly, powerful, unique. I mean, they exchange millions and millions of health records every single day. People say, "Oh, it's hard to interoperate with Epic," but the truth is that when our doctors see a patient, they have access to every piece of data from any other Epic instance that they know about, and that is really, really powerful. And is not something that easily could replicate elsewhere. But with that said, if I'm going to pick one, of course we're going to pick the one that I happen to know the most. Two, that is rated over and over again the best EMR in comparison to the rest. And three, has absolutely the largest market share by many leaps and bounds.
That totally makes sense. Another question I wanted to ask you about, you alluded to this a little bit. Because one of my questions is going to be, how do you get, combat inertia with health systems? They're notoriously a little slow at making decisions and committees and all these things. But you did mention another way to look at this, if you were thinking about this as a sales VP, is you're pushing pain points. Which pain do you have? This one, or this one? You're not claiming to have the benefits, you're talking about the problem. So is that really the secret to break through and to get something going with them, is just focusing on their pain? Or are there any other secrets to, helping to their benefit these health systems move in directions that are, positive and win-win?
Yeah, let me speak generically for a second. The health systems are like the proverbial elephant, and depending on what, blind man touches, they're going to feel different things. It's the same way. Every health system's a bit unique. Every health system has a CEO and a CMO and a CIO and et cetera. And yet those people at that organization might be different. The CIO at one organization might really just be focused on sort of minimal technical stuff, where a CIO at another organization may be profoundly involved in clinical technologies and may be called or maybe have the same ideas as a chief digital officer these days. And so how and where we get in depends a bit on the organization. They're all a bit unique. But what we commonly see is some combination of the technology team says, hey, it has been told, like, hey, we need a virtual care partner. And they may have already, over half the time, we're replacing one they already have. So, which is not easy to do, but actually works out really well for us. So the health systems made a decision. We want a virtual care partner. We need someone to do this. They've been using another third-party partner, but those people are on a completely different technology, requires constant interface and integration upkeep, and the patient has a bad experience because that's in a different system, and the data isn't shared, and the doctors aren't happy. We come in and say, hey, you've already made the decision that you're willing to share some of the care. Why don't you work with us? Because it's going to be a better patient experience, better doctor experience, better, more financially viable for you. And so we have been replacing, in a lot of cases. That's easier. De novo, starting from scratch, is often a little harder because they got to figure out, should we do it ourselves? Should we work with you? A common story is them saying, we're going to do it ourselves. 6 months later, they come back, go, yeah, no one did anything. Yeah, we keep saying we're going to do it, but no one actually does anything internally. And the cool thing is the way Epic has set up this interoperability is not just data interoperability, but I mentioned they actually set up something called Telehealth Anywhere, which is a functionality that allows us to connect to another health system and allow us to be available within the health system's own MyChart record. So from a patient perspective, it's super easy. From a CIO's perspective, we literally, all they have to do is flip a few switches, and Epic already has the technology to connect our instances. So we've made IT happy. We've made the CFO happy because increased access, increased volume is something they always want. The head of access is happy. The biggest risk might be the head of primary care who said, oh, we can do it ourselves, but then doesn't do it, and then is struggling with sharing the care. In other places, the heads of primary care are like, this is great. We would love for you to take off some of the stuff that we don't have time to do, that our doctors are overwhelmed. We have 30, 60-day waits because our doctors are overwhelmed with doing small, minor things or annual wellness visits or little stuff. If we could shift that to you, even better. So again, it depends on how the health system's set up. And sometimes you can't please all the people all the time, but as much as we can, our goal is to please all the people all the time. Make the technology people happy, the clinical people happy, the financial people happy for this to work.
Well, the one thing about building it on your own that by the way, I just went through this myself personally. I read a book years ago called Scaling Up. It's one thing to read a book. It's another to implement it across an organization. And so multiply that times the effect of a health system. And, one thing that I would just say, it's an obvious to me, is this isn't a technology issue. This is a recruiting issue. You have to get the right people. It's like just the technology is the part we're talking about here, but finding the right doctors, getting them on the same page, recruiting is a huge topic here. So even if they have the right platform, they have to go out and recruit. That's something and do that in your spare time.
And to do it for something that winds up you lose money on because you have a much higher cost basis. We are very asset light. And so I can see a high volume of minor type things and still make money on it. It's harder for a health system to do that. But I'll suggest that not only is it that recruiting and economies of scale, or especially recruiting people who do stuff in the evening or 50-state coverage, but what we're also doing is we're putting a lot of time and money and energy into making our Epic instance highly, highly optimized for virtual care. So for us, saving 2 minutes on a visit, becomes really important because of the scale that we're doing. For a health system, they're not going to spend millions of dollars to make urgent minor care really efficient. For us, we're going to do that because we're scaling across. We've got 20 plus health systems now, 50, 100. It starts to make sense for us to do it because we can create economies of scale that any individual health system won't have. So when we build technology into our system, it's a combination of one, how do we fine tune and tweak what Epic delivers? And they keep coming out with more and more really cool stuff. Number two, if and what might we use from the Epic App Orchard, their showroom, all the partners who are building cool stuff for Epic, we have our choice of that. Or three, we can build some of our own tools. We have our own tech team, and we're building some of our own tools that Epic themselves isn't building, or we don't see partners building it, or maybe we find it's just better, faster, cheaper for us to build it ourselves. The result is we're not just giving health systems and others a workforce. We're giving them AI, tech-enabled, optimized workforce that can do the same amount of care better, faster, cheaper than they could ever hire themselves to do because they're working on their standard Epic instance, which is optimized for the office. We're working on an instance that's optimized solely for virtual care.
So you brought up something earlier that I thought was a great insight that I've actually wondered about, which is, the urgent cares or the family practice groups we've worked with or the systems integrating telehealth. I could see why that would be hard. It's a whole different mindset. And, how do you switch from one to the other? It's my individual workflow. So I could see why that's an issue. So a related operational issue or human issue is getting the individual doctors to buy, and whoever else is involved to buy into this, to change habits. Like, how do we get them to really think of you? Okay, we've got a contract on a system level, but how do we get to actually stir usage? And I want you to frame that with, you said something on our last call when we were preparing, making doctors happy and patients healthy. So I'm assuming that could be part of this. So I'd love to hear about that part because it just, for me, it's like once you've crossed the finish line and signed a contract, that's not the same thing as utilization. So I'd love to know more about that.
So there are two parts to it, or two or three parts to it, and some subparts. So part number one is before the doctor's ever involved. Just when a patient calls, right, they're calling the call center, they're going to MyChart, et cetera. And so the health system has the opportunity to take these entry points and say, hey, what and how do I ask and propose to the patient based on, you can, within Epic, you can actually propose a couple of questions that are asked. And if what you have is a minor urgent thing and you want to get seen today, we can say, look, there's no appointments available now. I could tell you just go to the ER or urgent care, but I also have this group that's available that takes your insurance, and I can point you in that direction. And you can click a couple buttons and be on a call with them, a video visit with them in the next 10 to 20 minutes. We just have to make sure that it's clear and obvious for patients that they are aware that this even exists, right? Because they don't know. And so we have to make sure if they're coming in through the call center, through MyChart, the website, that we improve awareness that this is available. Number two is how do you get the physicians bought in so that they themselves are telling patients, hey, this is a good, safe thing. Hey, I can't see you today. Why don't you go here? So to do that, I call it the 3 C's, and that is as follows: to get physician adoption. C number one is they have to feel the care is coordinated. They have to feel very comfortable that if they're going to send you to another doctor, that the doctor has access to your records and shares their records back to the primary doctor. And that's what we do. And so that's why they've traditionally not been very happy about sending patients to a third party, but they can feel better about us. C number two is what I'll call compensation redesign. And this may be the most important thing you brought up before, again, reimbursement. Bottom line is this: if you as a health system pay your primary care doctor a base salary and bonus based on RVUs, then they're going to be incentivized to get as many RVUs as possible. So seeing quick, easy stuff is a way to boost up their RVUs. They're not going to be happy about sharing patients, et cetera. So if you really want to get their buy-in, you've got to think about, from their perspective, how are you compensating them? The most, at the very least, a straight salary, regardless of RVUs, starts to at least make them feel not bad about sharing. But if you can pay them based on their panel size, and then give them a team to help them expand their panel size, all of a sudden you have alignment. And that to me, and we're starting to see that in some health systems, is going to be the most beautiful, obvious thing where all of a sudden the doctor says, hey, look, I don't have to see everybody in the office all the time. I can start load balancing and sharing the care with this team. And that allows me to expand my total panel size and get paid appropriately to do that. Everybody wins in that scenario. And yet, because it involves physician comp redesign, a lot of people have angst over it. My suggestion is don't try and do it to everybody. Pick a couple of doctors, 2, 3, 4 doctors to start with, show that it can work, and then spread after that. The third C is sort of cultural changes. This is doctor, patients, staff just feeling comfortable with the concept of virtual care, that it can be effective, etc. But if you don't get comp redesign, it's going to be hard to get doctors to really buy in and promote this.
That's brilliant. I can see how that would work. It's, again, any organization trying to get people to work together towards common goals as opposed to cross purposes is going to be really hard, especially in healthcare, where it's hard to think of any industry more complicated. And, where there's, we didn't all design healthcare from scratch to get here, right? It's kind of grown, and it's like a room or a house with 75 rooms that were added on over time.
I love this. This guy named Joe Flowers was a futurist. He wrote this great article years ago, which basically said it's a big game theory, right? It's like the Nash theory, game theory, in the beautiful mind. It's complicated, weaving of things that happens, but it's working, so to speak, and it's very hard to go in there and move someone's cheese. And again, this is my experience as a doctor who's been on comp committees for the past 30 years. You don't move someone's cheese without giving them some extra cheese. It's not rocket science. I'm very simple, but you don't go in and say, oh, but it's good for the patient. Oh, it's good for the. It goes, no, you're not going to get doctors adoption if you don't make their life easier and better financially.
That was a great way to end, and an excellent quote. We'll probably promote. We'll have your LinkedIn profile on the written form of this, the blog summary, the podcast summary, as well as a link to the website. Any other final thoughts about this? This has been, as I knew it would be. It's going to be fun. Any additional thoughts or things we should have covered that we didn't get around to, or things you'd like to emphasize?
Yeah, one of the quotes I often like to talk about that drives me is I'll say, we don't have a shortage of physicians in this country. We have a shortage of using them efficiently. Whether we, use tech to amplify the doctors in the trenches in the office, how we use it to amplify the virtualists, et cetera, is going to be a really important part of our future. We're going to see, for a health system to transform, they can't simply do the things that they're doing a little faster. They've got to really rethink how they manage a population. The truth is, much of what we're doing at KeyCare is focused on bringing population health and team-based care to life in a world where we can truly now execute on it because virtual care is more accepted and because it's reimbursable. We're not inventing a bunch of new ideas per se. We're taking what many have known for a while, what Kaiser has been doing for many years, and just saying, what if we can start applying this to more and more places? And if we do it right, we get a world where patients get more access to care. Doctors are able to focus on maybe top of license. And ideally, imagine if you could go to your doctor's health system and say, hey, good news, we're going to decrease the number of patients you have to see in the office, while we're going to increase your salary and allow you to see a bigger panel size. And we're going to give you a team that makes sure that the quality of care is being more evenly distributed amongst everybody, and everybody gets what they need. So we can actually improve access, cost of care, quality of care, patient experience, and physician experience all at the same time. We can do this. And people say you can only choose 3 of those, but I think we can do it all. The offset may be, people wind up in the ER less, but these days, that's not a bad thing. Even for the ERs, they don't want to see a bunch of lower complexity care. So it's a big vision, but it's possible where it wasn't possible before.
Well, I think we're in enough pain where, health systems and others are probably willing to try something because you can't squeeze that lime. Everybody's already talking about burnout. You just squeeze the lime harder, eventually, the lime falls apart in your hands. And so I think that's where we are. So, but it is such an innovative idea. I wish we had more time we could talk about. For example, you were talking earlier about the triage there with AI chatbots answering calls. You can all these things could be so much faster and getting people.
I think virtual care has the most promise for being able to truly automate a big chunk of care. You still need a doctor, but imagine if instead of the doctor spending 20 minutes with the patient, the AI spends 15 minutes and the doctor just spends 5 minutes, but you get, much more efficient use of the doctor. Right now, you've got a doctor who can see many more patients, but do it in a way online that where the patient still gets everything they need and the doctor is able to focus on the really cool stuff a doctor can do rather than have to focus on, tell me if you smoke, this, that, and documenting everything. Ambient AI, of course, is something we use and has been helpful, but even better is capturing more and more of that information ahead of time.
Lyle, it was fun. I appreciate your time. Great job. Lots of insights. It's exactly what I love on these is when we get some insights that are new to me and the audience. So I appreciate your time.
Thanks. Appreciate the conversations. Good stuff.
Good. Thanks.